Thank you for the opportunity to talk on the topic of planning resection of perihilar cholangiocarcinoma. This is one of the most difficult tumours to stage and treat, and as such I'm really not going to give it a huge amount of justice by the time that we've got here today, but we'll work our way through the principles around how one goes about staging for resectability. So cholangiocarcinoma is a tumour that arises within the cholangiocytes anywhere from the intrahepatic bile ducts down to the ampulla in the head of the pancreas. It can be broadly classified as intrahepatic or extrahepatic. It is the perihilar cholangiocarcinoma for which we are primarily interested in today with regards to this talk. It is the tumour that arises anywhere from the second order bile ducts down to the common bile duct at the junction with the cystic duct. It makes up just over half of all cholangiocarcinomas that are seen. So what are some of the issues around determining resectability in patients that present with presumed perihilar cholangiocarcinoma? I guess up front it needs to be stated that hilar cholangiocarcinoma is an aggressive malignancy with R0 resection being currently the only option for long-term survival. So determining resectability is paramount if one is going to try and achieve cure. With regards to the issues around this, firstly, there is no preoperative staging system to predict resectability. Secondly, it often arises in patients with chronic inflammation such as PSC, which is associated with an impediment to the underlying liver synthetic function, which does limit resectability. Unfortunately, only a minority of patients that present are suitable for curative resection, and due to the location of this tumour, it's often difficult to obtain preoperative histological cytological confirmation. The role of biliary decompression remains controversial, and treatment of perihilar cholangiocarcinoma is challenging and includes both surgical resection combined with neoadjuvant or adjuvant treatment, including radiation treatment and chemotherapy. But again, there is no standardized treatment protocol for this tumour. So how does one stage hilar cholangiocarcinoma? The classification that is best known would be the Bismuth and later modified by Collette staging system. Essentially, it is an anatomical description of where the tumour arises within the hilum. It can be broadly classified into 5 different groups. The issues with this classification is that it does not take into account the longitudinal extension of the tumour. It fails to consider vascular involvement, does not take into account any nodal or distant disease, and does not consider the parenchymal volume. Also, it has not been shown to have a relationship with the patient's prognosis. The AJCC classification or staging system really doesn't have a role preoperatively because the histopathological classification of the tumour is necessary in order to obtain the AJCC stage. A less used grading system is that which was proposed by Leslie Bloomgart back in 1998, which breaks patients down into one of 4 groups based upon what they say is the T stage, but that also takes into account vascular involvement in the size of the future liver remnant. It's a very simple system, and it separates the patients into one of 4 groups which do appear to also correlate with patients' resectability. So what are the criteria one needs to consider for the assessment of resectability? There are 6 factors that need to be considered. The first is an absence of extrahepatic disease, followed by presence of regional lymph node metastases or the extent of the regional nodes, the ability to achieve an R0 bile duct margin on the future liver remnant, extent of involvement of the portal vein and arterial branches, and finally the volume and function of the future liver remnant. To help us work through these variables, here's an algorithm that helps to consider all of these aspects. I'll work our way through this algorithm and work out the systematic type process which one can use to try and look for whether a patient is resectable when they present with suspected cholangiocarcinoma. So how does one make the diagnosis? Well, it's not as simple as one hopes. Essentially, the presence of a malignant appearing structure with at least one of the following: malignant cytology or histology, an elevated CA19-9, polysomal on FISH analysis, or a malignant structure with a mass seen on cross-sectional imaging. Ideally, the diagnosis is made using non-invasive imaging with characterization and correct localization of the tumour. Unfortunately, symptoms are not helpful, and the non-invasive imaging is really down to ultrasound, CT, and MRI. Serum markers such as CA19-9 are helpful, and one does need to look at the IgG4 level to exclude the autoimmune condition that can masquerade as a tumour. Invasive cholangiography may be needed by the ERCP or PTC, and staging by EUS, PET, and laparoscopy should be considered. So what about ultrasound? It's very operator dependent and has variable sensitivity and specificity. One advantage is that it does show a colour Doppler flow. CT is the most frequently used modality and remains the real workhorse here in establishing resectability. It shows excellent visualization of both the local tumour extent, the vascular invasion, and staging of metastatic disease. We obtain 3 phases: arterial venous delayed phase as well as a non-contrast, in order to answer many of these questions. It also offers us ability to assess the future liver remnant volume. Although MRI has better visualization of the biliary tree by MRCP showing cholangiography, and on its own, looking at the parenchyma and the tumour, it does not really offer any addition over CT. It is limited by longer acquisition times, motion artifact, lower spatial resolution, and especially in the presence of stents, you get image artifact, which prevents accurate characterization. The role of FDG, CT, PET remains limited, and it really doesn't have any advantage over CT or MRI. Its principal role really is for identifying metastatic disease or lymph node involvement beyond what would deem to be resectable in the hepatoduodenal ligament. There's a high rate of false positives which need to be considered, especially in the presence of chronic inflammation. In selected patients, the diagnosis requires invasive examinations by ERCP, PTC, or EUS. The consensus regarding the utility of these investigations is not really agreed, and their role is somewhat up to the individuals and the patients that have been assessed. Essentially, this study back in 2008 showed us that undertaking MRI with MRCP sequencing is comparable to undertaking CT with direct cholangiography by the PTC or ERCP, showing that invasive cholangiography is not really offering us much in the way of advantage over what we can achieve by non-invasive methods. So if you are going to undertake PTC or ERCP to do cholangiography, which one do you perform? Well, again, there's no consensus. PTC is more desirable, in my belief, compared to ERCP, because it helps define the tumour involvement in the region of the bile duct, which one is going to anastomose onto the jejunum. Also, endoscopic approach is thought to be associated with an increased likelihood of requiring an additional procedure or causing cholangitis. It really comes down to the local expertise and in your centre where the preference is with regards to how you approach the cholangiography. Cytological sampling is able to be attained often by these techniques, which may be helpful. Problem is, although it has a high specificity, the sensitivity is relatively low. Various techniques have been used to try and improve this sensitivity, including FISH analysis, which has been popularized by the Mayo Clinic, and really it should be used in those samples on cytology that remain equivocal or negative when there's a high index of suspicion. I think in the last 5 years or so, cholangioscopy and biopsy has made a further advance. Direct visualization of the biliary tree using spyglass or spy-bite biopsy forceps is performed by either PTC or ERCP. You're better able to detect the longitudinal extent of the tumour, and it has recently been shown to have improved sensitivity and specificity over cholangiography. So where does endoscopic ultrasound fit? Essentially, it is there for staging the tumour in a more distant role, not confirming the diagnosis, as an FNA of the perihilar tumour is associated with a risk of needle tract seeding. In this series from the Mayo Clinic showing 83% of patients with a history of a positive FNA developing peritoneal metastases following transplantation. So its role is really to look at visualization of regional lymph nodes and or assessment of associated vessels. Serum markers can be helpful, namely CA19-9 and CEA. The principal confounder with CA19-9 is the presence of jaundice, or in around 7% of the population, Lewis antigen is absent, so they will not produce CA19-9. I'll just make a point here of measuring IgG4 in patients with hilar strictures, as autoimmune cholangiopathy can masquerade as hilar cholangiocarcinoma. So in the patients which we have suspected hilar cholangiocarcinoma, we've completed the assessment by imaging and or undertaking other invasive tests. And it appears that the person is potentially resectable. What are the next things to consider? The first thing would be the bilirubin. Is the patient jaundiced? Placement of biliary stents is controversial. Essentially, sepsis secondary to cholangitis, not responsive to antibiotic treatment, is the only absolute indicator for biliary drainage prior to liver resection. Jaundice, pruritus, or cholangitis alone are not indicators to drain the biliary tree, especially prior to completion of the staging. The placement of a biliary stent or endoprosthesis may hinder the staging and cause imaging artifact. We do know that an elevated bilirubin level is associated with an increased postoperative morbidity when it's above 40 and mortality when it grows above 100 in patients undergoing stage 1 resections. And this needs to be considered in the timing of patient surgery. So where does staging laparoscopy fit in? Laparoscopy is able to detect small liver and peritoneal metastases so as to avoid a futile laparotomy. Its role is decreased due to improvement in imaging techniques, and really it's only something that should be considered in patients which have T2 or 3 tumours where it's in potential involvement of vascular or parenchyma, or those that are said to be type 3 or 4 by bismuth. It has been shown by meta-analysis to reduce the chance of a futile laparotomy, and the addition of ultrasound may improve its sensitivity. What about CT volumetry? Well, this can be relatively easily performed nowadays due to good software on most scanners. In the presence of a small future liver remnant, that is less than 25%, there's a threefold increase in the risk of postoperative liver failure. So in these patients, one should consider a portal vein embolization with biliary drainage to induce hypertrophy to achieve a remnant that is greater than 30%. ALPS currently isn't recommended due to a series of patients showing a high mortality rate. Not only the volume, but the quality of the liver remnant is important here. And one should consider undertaking a technetium labeled scan or IgG clearance in order to try and look at the functional aspects of the future liver remnant. So if one gets to this point, then you need to consider a laparotomy in order to explore the patient to ensure you can obtain an R0 resection. So although this is a brief synopsis of staging, I guess the principal points to take away is that hilar cholangiocarcinoma remains one of the most difficult tumours to diagnose, stage and treat. It's an aggressive malignancy, with R0 resection being currently the only option for long-term survival. There's no universally accepted staging system or definition of resectability. The aim is to complete staging using non-invasive means. One needs to exclude autoimmune cholangiopathy by measuring IgG4 and potentially undertaking invasive cytology or histological analysis. Biliary drainage by either pTCA or ERCP remains controversial, but avoid it until you've completed the staging. It's not only the quantity, but the quality of the future liver remnant that is important. For extended resections, have a low threshold to induce hypertrophy of the future liver remnant by portal vein embolization and biliary drainage if your remnant is less than 30%. Engagement with tertiary centres with experience in managing these patients is paramount if one is going to try and achieve excellent outcomes. Thank you for your time.